Hello everybody, my name is Leandro Leite, I'm a dermatologist from Brazil, and today I will record a video on a year in review. So, so the idea is to present selected highlights from recent advances in psoriatic disease. This review was done in March 2026, so the main articles presented here are from the last year. And of course, this is a selection of the topic, and many aspects may have been left out. So we will start with new guidelines. So two previously unmet needs for guidance were addressed last year with the publication of specific guidelines. The first one was the definition of failure of topical therapy in psoriasis that was defined as the inability to achieve clear or nearly clear skin after two consecutive courses of 4 weeks of topical therapy. And it strongly recommends to take the patient self-assessment in consideration to progress the therapy for systemic therapy. The other one was the definition of remission in plaque psoriasis that was defined as maintaining BSA or IgA of 0 for at least 6 months while on treatment. It was also a year for a better understanding the connection of skin and joint in psoriatic disease. In this study, they performed single-cell RNA sequencing and spatial transcriptomic, and they identify identical CD8 T-cell clones both in the skin and joint of the same patient. So if we take the patient 6 skin, for example here, and we follow this thick purple lines, we can see that it is the same clone on the patient 6 synovia. So it suggests the migration between sites to propagate the disease, and those shared T cell clones would play an active role driving chronic inflammation across different organs. It supports the idea of a unified disease instead of skin and joint disease or joint disease, but a shared immune network. But not only T cell migrates, also myeloid cell migrates, as we can see in this animal model of psoriasis, that they identify a specific population of myeloid cells that migrate from skin to joint in a two-step biological mechanism, very similar to tumor metastasis, that you not only need to migrate, but you also need a permissive local tissue environment for the migration. And this permissive environment in the joint, it happens when the myeloid cells surpass the joint resident fibroblasts. So this specific population of joint resident fibroblasts, CD200, they inhibit the migration. And if the myeloid cells surpass them, they can subsequently control the production of IL-17 by T cells. It was also a year for an update on genetics. This meta-analysis of 18 genome-wide association study identified 109 distinct susceptibility loci, including 46 new ones. The new ones here are the green ones. And basically, this genetic data validates existing highly effective approved treatments that we have. They identify genes related to psoriasis for the IL-23, the TYK2, and also TNF, and finally the receptor of IL-17, which is a target for brodalumab. And also validates new drug targets, for example, the AHR receptor that is activated by tapinarof, and finally provides evidence that increased adiposity leads to an elevated risk for psoriasis. And we all know how complex is the association of psoriasis and adiposity and metabolic syndrome and obesity and cardiovascular disease, but last year it was in high evidence. On this study, they investigate which kind of adiposity leads to a higher risk for psoriasis, and they identify that the central adiposity leads to higher risk for psoriasis, and that risk is greater in females and in patients who are negative for the HLA C0602. We know that this HLA is the most important genetic predictor for psoriasis, and through a Mendelian randomization, they found that both at HLA and adiposity, they both increases the risk for psoriasis independently from each other. And we have several other studies that address this association on last year. I will mention some of them. So the first one here, they investigated residual inflammation in patients with psoriasis that achieved a PASI less than 2, and they defined residual inflammation as a CRP higher than 2. And this residual inflammation was strongly associated with a higher body mass index. On this other study, they investigated a spatial proteomic profile in patients with psoriasis, and they find that there's a huge, strong spatial molecular heterogeneity, specifically in the inner epidermis of the patients of the psoriatic lesions, and specifically with upregulation of the entire cholesterol biosynthesis pathway. And the authors proposed that cholesterol-lowering drugs could have a potential therapeutic strategy, serve as a potential therapeutic strategy for managing psoriasis. And finally, this very good review of the overlap of cardiology and dermatology address several interesting points of both specialties. For example, the skin signs that act as clues for cardiovascular disease. For example, the genuine lesion in the Osler nodes for infective endocarditis, and the xanthomas for underlying dyslipidemia. But specifically with a focus on psoriasis, they pointed that psoriasis is strongly associated with atherosclerosis, myocardial infarction, stroke, and cardiovascular death, with a 5-year reduction in life expectancy in patients with moderate to severe psoriasis. And we also have a trial on Mediterranean diet as an intervention for patients with psoriasis that found improvement in psoriasis, and that improvement was independent of weight loss. And finally, the two trials, Together PSA and Together PSO, that investigated the combination of ixekizumab and tirzepatide versus ixekizumab alone to treat obese patients with PSA and PSO. And the primary endpoint was achieving a PASI 100, PASI 100 and ACR 50, and having more than 10% of weight reduction in both diseases. And of course, patients using the tirzepatide, they lost more weight. But if we look only to the disease activity, that's very interesting. So the combination was superior in achieving PASI 100 and ACR 50, both in psoriasis and PSA. Also, last year was the year of the oral medications. So I put them here all together to make things easier, to make things simple to visualize, but please don't take that as a direct or indirect comparison. So we start with deucravacitinib that we all know that is approved, and icotrokinra here that was recently approved only in United States. The other drugs are not approved yet. And here they're divided by the stage of development that they are. We have deucravacitinib and zasocitinib on phase 2 and also on phase 3, and also icotrokinra on phase 3, and the others, and vudelcitinib, ICP-488, and D2570 are in phase 2 studies. And here they're divided by mechanism of action, so icotrokinra is the only IL-23 receptor antagonist, and the others are TYK2 inhibitors. So that's why they are called the next generation of TYK2 inhibitors, because they have a higher efficacy compared to deucravacitinib. And I would mention also that ICP-488 and D2570, they only have data in Chinese population. And maybe new ones are coming. An oral TNF inhibitor and an oral IL-17 inhibitor maybe would be available in the next years. And this is it. Thank you. Thank you very much.